Generalized pustular psoriasis (GPP) is generally acknowledged as a rare and severe condition due to its low prevalence compared to other forms of psoriasis, where the disease is categorized by widespread patches of skin with sterile pustules. Talking about the rarity of GPP, well, it may also be attributed to the fact that psoriasis itself is not extremely common, affecting about 2 to 3% of the population. To give us more and better insights on the subject, we will be speaking to the expert itself, which is Dr. B.S. Chandrashekhar, who is the Chief Dermatologist and Medical Director of Cutis Academy of Cutaneous Scientists. Let's jump in. Okay, so as we know that in today's segment, we will be talking about a very rare condition for that matter, which is generalized pustular psoriasis, which we also call it as GPP. So the first thing that I would actually want to ask is that what are the subtypes of generalized pustular psoriasis, that is GPP?
Okay, when it comes to classification or subtypes, we have two types majorly, which depending on the occurrence. De novo, it can start by itself. And the second variety is a plaque psoriasis can get converted to a pustular psoriasis. Coming to the morphological types, we have acute generalized pustular psoriasis, we also call it as von Jambus disease. The second one, you can have annular plaques where you see the border is studded with the pustules. And of course, it can be one of the form of an exfoliative erythrodermic psoriasis. And there is a localized form also. We call it as halopy disease, which affects the fingertips. Then it also can be a palmoplantar pustulosis, where you see the pustules only in the palms and soles. These are localized varieties, and one of the generalized variety which really threatens dermatologists as well as pregnant women is the GPP which occurs in pregnant female. So that is impetigo herpetiformis. That's what we call it as. So that is one variety of GPP, which really threatens, the life of the mother, life of the kid inside the womb. Then the dermatologist. That's it. Yeah.
So, like you mentioned, it's really harmful for the pregnant ladies, something new that
Yes, because it's tough to treat, because you have limited options to treat. You have only one drug, cyclosporine, nothing else you can use. And it is really a thing which we will be on our toes to treat that condition during pregnancy. Yeah.
Okay. So with that, doctor, can you elaborate on the reported causes of acute generalized pustular psoriasis?
Okay, as I told you, two categories. One is a de novo, sometimes idiopathic. We don't know, suddenly it arises. The second one is a patient who is suffering from chronic plaque psoriasis, probably when they use steroids, either oral steroids or topical steroids. Suddenly it comes. That's why all dermatologists, we always tell psoriatic patients to be extremely careful about using a high dose of topical steroid or oral steroids for any other purpose. Second, the infection, any infection cause, then there are vaccinations. If you take H1N1, even we have seen it happening in COVID time with the vaccine. And of course, the stress related, then heavy smoking, heavy drinking can also bring about pustular psoriasis. Then sometimes, you have other diseases, associated disorders that can also bring about pustular psoriasis. But majorly it is staphylococcal infections, withdrawal of steroids suddenly. Those are the major causes. Of course, pregnancy is one of the causes for the psoriasis to get converted from chronic plaque to a pustular psoriasis.
So those were some of the reasons. So with that, what is the significance of genetic factors in the development of GPP?
Of course, GPP is a disease which has got a genetic background because there is a lot of research which has gone into the genetic predisposition. Normally, overall, if we take the HLA association in psoriasis, it's HLA-B27. But the research into psoriasis has gone so deep. Now we are talking about cytokine levels. So if the patient has got an antagonist IL-36 deficiency, they are prone for GPP. And of course, as I said, any HLA-B27, patients who have got this myeloperoxidase deficiency, patients who have got, we call it as SERP1, SERP2, those are the genetic markers, the deficiency. And these are all the patients. And also there is an important CARD14 domain in which the genetic influence is there. These are the patients who get, either they get a GPP or they get the localized pustular psoriasis. Yeah.
So with that, what are some of the treatment modalities for GPP, doctor?
Of course, it depends on the condition severity. Of course, in an acute generalized pustular psoriasis, the first thing we do is hospital admission. because these patients are notoriously known for electrolyte imbalance. They will have hypocalcemia, which can lead to a lot of metabolic syndromes associated. Plus, it can lead to a endangering of life. So there, probably we use a crisis buster drug called, the cyclosporine, and we also can use acitretin. Of course, there are newer biologics which have come. Of course, they are not present in India. Maybe we'll have to wait for another couple of years to come. Called Spevigo, which is a specific biologic for pustular psoriasis called spesomimab. So I think that is one of the wonderful drug which has been revealed recently in European Academy of Dermatology and Venereology Congress. If it comes to India, I think we are going to win the acute crisis of GPP. In a pustular psoriasis of alveolar type, probably we would give acitretin orally. Probably we can also manage with topical calcipotriol, which is vitamin D derivative, topical steroids for that matter, topical tacrolimus. Of course, we can manage localized psoriasis. But for systemic, these are the drugs. As of now, cyclosporin is acitretin. These are the drugs.
So, doctor, there's one more thing that there is a lack of research in the treatment of pustular forms of psoriasis. So, how does the rarity of the disease contribute to the challenge?
There are two angles here you will have to look into. One, the research facility we have in India. We are really bad at having research facility at even at the premium centers. Also, they don't have the lab for genetic mapping, and all these things are very difficult. Number two is that by the time the patient presents to us, probably they would have taken treatment from a general practitioner or an Ayurvedic physician. So it's all mixed type when they come to me. There are a lot of infections and a lot of things. And our motto first is to settle the patient out, because you have to bring them from the crisis. So in that way, we have a very limited resource for research and investigations. Of course, for the routine investigations like the calcium levels and routine blood tests are done. But when it comes to a research angle like genetic mapping or getting into the root of the disease where we can treat, developing a target approach to that, of course, that is the paucity in India. No, we don't have such facility.
So, like we talked about that. So, what are the challenges that we face by the management and treatment of pustular psoriasis and the forms of it? And like how are the health experts navigating these challenges?
Okay. Of course, you know that it's a medical emergency. If there are a few dermatological emergencies, one is the toxic epidermal necrolysis because of the drugs. Second one is this generalized pustular psoriasis. So when the patient comes to us, first thing we do is admission. Then we start our drugs, crisis buster, cyclosporine or acitretin. Having said that, the patient presenting to a dermatologist, because there's a variety of pustular psoriasis. One, you have a generalized form, you have a localized form, which is also affects the palms and soles. So we have different varieties of treatment to treat these conditions. So that's how, depending on the classification or the clinical presence, clinical manifestation, we need to tackle the psoriasis GPP. The second challenge is that it is notoriously known to recur back. So for the recurrence of psoriasis, when we are challenging my patient with immunosuppressive drugs like cyclosporine, methotrexate, and some biologics, I'm endangering my patient for an opportunistic infections. So that becomes a challenge. You know that there is a rampant H1N1 around us, and if the immunosuppression goes, the patient would get into that particular arena and he will have a problem. So really, it is challenging because it is a rare disease. The armamentarium for treatment is less, so it is challenging.
Okay. And with that, how can government ensure affordable and accessible treatment for patients with GPP?
See, one of the problem what we have in India is that the psoriasis as such is not included in what is that government category of diseases where you have an insurance facility. So we don't have insurance facility for psoriasis, and you know that there are a lot of biologics available in India which are super expensive. Probably a course of treatment for psoriasis for a common man could go up to 2.8 lakhs for the first 10 injections. That is the cost of treatment. So the government agencies, only a central government hospitals like ESI and military hospitals have got biologics, but other hospitals they don't have biologics. So in that scenario, the government has to make it sure that there are target novel therapies for this kind of psoriasis diseases, that ensure that some of the biologics will be made available in the hospitals. And from the insurance companies, they should include psoriasis as one of the disease. See, psoriasis is not a skin disease. It's a systemic disease. We have a lot of psoriatic arthritis. It can involve the cardia. It can cause myocarditis. It can cause gastrointestinal system. So what you see is on the skin. What is there inside the body is a different arena altogether. So they should consider and include psoriasis as one among those diseases which really require insurance, so that it can be catered to a common man who suffers from it.
So, doctor, you mean to say that there is no role of health insurance in this regard?
There is a role.
Okay.
Health insurance people are not including psoriasis in their insurance.
Hmm.
And the government hospitals are not catering. Only the central government hospital like ESI and military hospitals are keeping biologics. But our state government hospitals, they don't keep biologics. And private insurance is required, but the disease is not included in there. See, they have a list of diseases, for that they give insurance, correct? Psoriasis is not one among them. And it's one of the metabolic diseases. They should include, government should put efforts on insurance companies, either to make them understand what is the disease. They can talk to the association of dermatologists and think and learn about the seriousness of this particular disease and include it under insurance, so that our patients will have a affordable therapy, targeted therapy.
Okay, that point we got. So, last thing that I want to ask is that from a patient's perspective, in your practice, what are some of the challenges that you have seen patients go through?
It's really a pathetic condition when they come with GPP. And as I already told you that since it produces pustules, they go to a general practitioner and they feel that it's an infection. So they would have put antibiotic. By the time they have taken antibiotic for 7 to 10 days, the disease is increased. It has become an erythrodermic. The patient is in a pathetic situation. And because the education level is lot of low, and this is a disease of probably lower middle and middle class and poor class families, the education about this disease is not there. That becomes a challenge from the point of patient. They do not understand what are they suffering, how long they have to go to treatment, and what is the cost of therapy which involves. So these are some of the challenges, and the recurrence of this particular disease is a challenge, not only from the point of dermatologist, but also from the patient's point of view. So this is how the challenges come from the patient. Affordability, then early detection of the disease, and coming to a proper dermatologist or a proper physician to get it treated, and long travel. Admissions may not be, some of the hospitals refuse admission because they have a pustular psoriasis, which is emergency, and they don't want to keep such patients. So we need to have a separate wards for skin diseases in government hospitals. So these are some of the challenges the patient really faces.
So I think from stating the basics to telling us about the challenges and the rarity of the disease, thank you so much, doctor. I think you've shared a lot with us in today's segment. So thank you, doctor. And I'm sure our audience will be able to gain a lot from this information.
Thank you. Thank you so much.
Thank you, doctor.